Welcome, everyone. This presentation provides a practical roadmap for writing a strong orthopedic clinical research paper. The key point is first to define the scope. This is research that uses patient data and aims to influence clinical care. So, common designs for this type of studies are cohort studies, case control, cross sectional, RCTs, or pragmatic trials. The core outputs are affecting some sort of an estimate, harms, generalizability, and decisions relevant conclusions. As an example, does fixation method A reduce reoperation versus method B? You need to clarify expectation. Most trainees will write observational studies and occasionally trials. A common error is forcing a design that doesn't match the question. For instance, for original articles and new patient data, for meta-analysis, you use original quantitative synthesis of existing data. And for case reports and series, you have hypothesis generating, however, lower level evidence kind of paper. Next, you need to spend disproportionate time here. This is the highest leverage step. Good PICO examples are in adults with closed trial shaft fractures, does reamed IM nailing reduce? So you want to have a very clear clinical question: population, who exactly, intervention and exposure, what is being tested, comparison, what is the alternative, and outcome, one primary outcome that matters clinically. Next, you make the argument why this study is worth doing. This is basically the sales pitch, but it must be evidence-based. You want to show the burden, prevalence, cost, disability, complications. You want to talk about the uncertainty, practice, variation, or conflicting evidence, and talk about the impact, what decision changes if your findings are true. And finally, feasibility. Can you measure outcomes reliably and ethically? This introduction should make this argument in 3 or 4 paragraphs. If you can't explain the clinical problem, then you have to rethink this. Then you have to do a literature search that informs your methods, not just your background. Trainees, more often than not, will read only the conclusions. Instead, read the methods and the limitations. You want to make sure that you borrow validated measures, prompts, radiographic criteria, or whatnot from others. Challenge the dogma. Older methods may be biased or underpowered. So ask yourself, did prior studies adjust for key confounders? Did they provide predefined outcomes? How did they handle the loss to follow-up? Your methods should be defensible and not merely conventional. Choose the right study design. Explain equipoise in simple terms. The community genuinely doesn't know which is better. Observational designs are common and valuable, but you must address bias, whether it's selection bias, confoundings, and multi-center increases generalizability and sample size, but adds coordination complexity. So key decisions: prospective versus retrospective, single versus multi-center. What changes between observational studies and RCTs? This slide frames why reporting checklists exist. Observational studies need clear definitions and confounder handling. Trials need allocation, concealment, blinding if possible, and consort flow. So both of these need pre-specified outcomes, transparent analyses, and honest limitations. Study population and sampling. This is where readers decide if results apply to their patients. So explicit inclusion-exclusion criteria are very important. Describing your setting, whether it's a trauma center versus community, and the level of surgeon expertise. These are all important things to be able to clarify. Track eligible, enrolled, and analyzed patients. Be precise. Adults with tibial shaft fractures is not enough. Open, closed, OTA, AO classification, polytrauma, etc. Even in retrospective work, describe the source population and how records were identified. Outcomes. Define, prioritize, and measure well. A common pitfall is too many outcomes. Primary outcomes should drive sample size and analysis. Avoid post hoc relabeling. Our primary outcome was dot dot dot. The reviewers will spot this immediately. So be make sure that you have validated prompts, you have standard radiographic definitions, you have clinically important thresholds, and stick with them. Bias and confounding. Name them and handle them. So selection bias. Who got treated and how? Is it included in your paper? Information bias. Is this misclassification of expertise or exposure and outcome? Confounding. Baseline differences that drive outcomes. And your tools. Multivariate models, propensity methods, sensitivity analysis. It's important to learn the bias mindset. Assume bias exists. Show how you mitigated it. Give a concrete example. Sicker patients receive different implants. Without adjustment, implant looks worse. In low resource settings, even a simple directed acyclic graph discussion can strengthen credibility. So address this head on, and key point is always assume that bias exists. Now, sample size and power. Very important to plan this before you analyze. Choose your effect size. Make sure that it's clinically meaningful. Make sure you have enough power for your study. You account for attrition and missing data. And if underpowered, be very explicit about this. Power analysis is not only for prospective trials, it clarifies what your study can detect. Retrospective studies can do detectable effect calculations. Do not claim equivalence or no difference from an underpowered data set. Now, statistical analysis plan. Again, simple, aligned, and transparent. What do these mean? Push people away from p-value hunting. Communicate precision. If you have clustering by surgeon or hospital, consider mixed models or robust measures. You have missing data, describe the amount, the pattern, and the approach. So these are important points to consider. Report your effect size and confidence intervals, not just the p-values. Predefine your subgroup analyses and handle missing data explicitly. Write with IMRAD discipline. So if it's not in methods, it shouldn't appear in results. If it's a decision or interpretation, it belongs in discussion. IMRAD is not a bureaucracy, it's a logical structure that prevents confusion. So in the introduction, you talk about why the question matters, what is the gap, and what's the objective and hypothesis of this work. In method, you talk about what you planned and what you did. You should give enough information so people can reproduce your work. And then in results, what you found. This is not the place for interpretation. Now in discussion, you start to talk about comparisons, limitations, implications, and interpretation of your work with respect to the existing literature. So here we have an example paper 1, a trauma RCT paper, the SPRINT trial. This is by Bandari et al., randomized trial of reamed versus unreamed IM nating for tibial shaft fractures. It was published in JBJS in 2008, and why this is a model. It has a very clear question, it has a multi-center design, and very patient important outcomes. So use the SPRINT as a gold standard orthopedic trauma RCT example. What you need to point out is clear eligibility criteria, multi-center recruitment, pre-specified primary outcomes, pragmatic relevance, and transparent reporting of harms. And you should discuss why multi-center matters, increases your sample size and external validity, show how the paper frames equipoise and clinical uncertainty up front. This is an excellent sample to emulate. Now, why is this an excellent template? Because the introduction states the clinical uncertainty. The methods defines interventions very clearly, what counts as reamed and unreamed, and addresses randomization and follow-up. In the results section, it reports the outcomes transparently, does not hide complications. And in discussion, It avoids overclaiming, acknowledges where evidence is stronger and weaker, for instance, open versus closed fractures. And also, this is a good example to sort of mirror this type of structure for your own papers. Now, example 2, another paper, an arthroplasty RCT aspirin versus rivaroxaban. So this is by Anderson et al. And published in New England Journal of Medicine in 2018. And why? It's a model paper because it has a pragmatic design, has clinically meaningful endpoint, has clear flow and analysis. You talk about very common clinical design. Aspirin versus DOAC strategy. Point at the clarity of your endpoints, symptomatic, VTE, bleeding, and the transparency of enrollment, flow, and analysis. So you need to learn how to write succinctly, short sentences, active voice, minimum jargon. Why is this trial so easy to read? This is a great writing lesson because the methods are reproducible. Eligibility, allocation, outcomes, and follow-ups are outlined. The endpoints are patient important and measured consistently, and the figures and the tables actually carry the message. The text follows and supports them. And in the conclusion, actually match the data. There are no exaggerations or over expression of findings. Now, some of the key importance, pitfalls to follow. Many tests increase false positive. Stress demonstrators always report and the analyzed and missingness. Language discipline. It's important to say associated with for observational studies. You reserve causes for RCTs because causation is a little bit different than association. So some of the pitfalls to really avoid are vague objectives or multiple primary outcomes, post-hoc subgroup claims without pre-specification, no confounder plans in observational work, overstated conclusions, proves, definitive words such as that, and poor tables and figures, missing denominators, unclear follow-up, and using too many adjectives such as novel, this or that in your presentation. Finally, your reporting guideline. Use these as a writing tool. Your strobe, your consort, these are not just acronyms. You use them for use strobe for observational studies, use consort for randomized trials. They don't guarantee good science, but they prevent avoidable omissions. These are not merely bureaucratic hurdles. They're checklists and that map sort of the peer review expectations. So it's good to follow them and be in the habit of using them as a guide. The write in the methods and results section actually while looking at the checklist. This will make sure that you have the right information in there so you can present things properly. Also, importantly, what is your take-home message? You close by returning to the theme. The goal is not publication. It is knowledge that improves patient care. The point is, even in resource-limited settings, strong questions and transparent methods produce publishable work. Use worksheets to design your study. So think about a clinical paper as a structured argument. You have a clear question. You have rigorous methods that you have thought through and used the literature to come up with. You're honest about your limitations. And if your study cannot change your decision, rethink the project. So think about these points clearly and well before you start the work, not after you have finished the work. So here in the appendix in this document, you will see strobe checklist. And these are the things that you want to follow. And make sure that you use these. That sort of like this is an abbreviated memory aid. For submission, use the full strobe checklist, which is appropriate to design. And also make sure that you use the Equator network for downloadable checklists that that are available online. So again, now for consort for RCTs, again look into this for trial reporting. Use the consort 2010 checklist and flow diagram. The key points are the concert forces transparency about who was included and what happened to them. Follow these, and you will be able to design studies that are well thought out, well conducted, and provide results that are meaningful to the readership. Thank you all, and I hope this has been helpful to you.